When a situational analysis is conducted, it becomes clear that PONV remains an issue for the postoperative patient. This is because of failure to identify those patients at risk, using non-evidence-based practice, anaesthetists continuing to use volatile induction agents, and cost-saving measures taking priority. And with the improvement of practice, management and medications, PONV is slowly reducing. In order to continue this trend, a standard must be created from best evidence which focuses on the management of PONV through proper screening and identification of risk factors, standard interventions, complementary therapies, and patient education. When all of this is achieved, PONV prevention can occur. The management of postoperative nausea and vomiting, PONV, is an essential part of the effective management of the postoperative patient. However, the prevention of PONV is something that is poorly managed during the immediate recovery period. PONV is a common complication following surgery. It reduces client outcomes and causes anxiety and distress, and is linked to physical, psychological, and economic complications. Although PONV has been a recognised complication of surgery for several decades, it remains a major problem for surgical patients. Patients indicated that it was the least preferred outcome of surgery, even above pain. This report aims to facilitate the understanding of PONV and educate about its proper prevention and management, using evidence-based practice for improved patient outcomes. PONV can be triggered by several perioperative stimuli, including opioids, volatile anesthetics, anxiety, adverse drug reactions, and motion, and has been shown to increase anxiety, decrease satisfaction, and increase hospitalization time. The primary reason that PONV remains an issue is the lack of a standardized policy or guideline for its management. As a result, hospitals have to develop internal policies based on research. However, given the vast amount of conflicting research, it is not immediately clear which is the best evidence from which to base practice. This results in policies which may not clearly identify those at risk of PONV and may prioritize poor management strategies. This in turn results in the development of PONV and far reduced patient outcomes. Conversely, if the correct practice is used, patient outcomes are improved, resulting in negligible occurrence of PONV, improved patient satisfaction, and reduction of prolonged hospital admissions. The best practice for management and prevention of PONV is composed of several interventions, namely prophylactic anti-nausea antiemetic drugs, hydration, narcotic analgesic use reduction, and use of non-volatile intraoperative induction agents. A combination of these interventions is essential for the management of patients with a high risk of PONV. There are several risk factors which contribute to the onset of PONV and include risk factors from both the patient and the procedure. These include patients being female, non-smokers, obese, having a history of PONV or motion sickness. Other risk factors include surgery time and type. The use of the Apfel simplified score to determine PONV risk is currently regarded as best practice. It identifies females, non-smokers, people with a history of PONV or motion sickness, and patients receiving opioid analgesics as having an increased risk of PONV. Each risk factor carries a score of 1, and a score of 4 indicates the highest possible risk. Be that as it may, PONV still affects 1/3 of all operative patients and up to 80% of high-risk patients. This indicates that the management of PONV is unexceptional. The use of anti-nausea antiemetic drugs should be considered for every patient post-operatively. Those patients who have been assessed as having a higher risk of PONV may require a combination of drugs with different actions to ward off PONV. There are several anti-nausea antiemetic drug guidelines for PONV which currently indicate that all patients should be prescribed ondansetron regardless of risk factor. However, for each of the risk factors listed above, these guidelines indicate the use of ondansetron, dexamethasone, intra-op propofol infusion, and scopolamine patch respectively for each score above 0 on the APFL score. However, these drugs have varied effectiveness, and as a result, with the exception of ondansetron, they are not often prescribed as first-line drugs for PONV in Australia. As an alternative, in Australia, the most common drugs prescribed are metoclopramide and prochlorperazine. These drugs have similar efficacy, thus no real difference has been seen in PONV cases in Australia. Hydration is imperative to the post-operative patient for various reasons, and it's particularly important for the prevention of PONV. Although several research articles claim that hydration preoperatively and intraoperatively have negligible effects on PONV, more recent articles have identified that although there is minimal difference in the immediate post-op period, patient outcomes are improved in the later post-op period if they receive pre-op and intra-op IV fluids. In particular, the best results were achieved when patients were given IV Hartmann solution at a rate of 15 milliliters per hour. The largest cause of PONV is the use of narcotic analgesics and volatile induction agents. Where possible, a patient who is of high risk should be prescribed non-opioid analgesics, and where not possible, they should be prescribed a medication with a short half-life, such as fentanyl, as these drugs have been shown to reduce incidence of PONV. This is primarily because the medication is used and eliminated from the body quickly. However, due to the increased price of fentanyl, it is often not used in clinically appropriate situations. In order to successfully overcome this practice gap, several things need to be achieved. In particular, the most important step is to engage in accurate risk analysis in the pre-op period through the extensive taking of history. Other steps to take include fostering a culture of prevention by avoiding cost-saving measures that reduce patient outcomes. However, the largest barrier to the successful management and prevention of PONV is anesthetist culture. When anesthetists move from a culture of "this is what we have always done" to a culture of "this is what is best for the patient," patient outcomes will be improved and PONV rates will reduce.